There you go. It's recording
Okay.
now.
Thank you.
Okay. Thank you, everyone. We are experiencing some technical difficulties, but good afternoon. My name is Bianca Santamaria, and I'm with the University of Arizona Center for Rural Health. Welcome to the webinar series. We're going to have people joining continuously, but we want to take a minute to express our gratitude to Dr. Mendoza for partnering with us to provide this very interesting webinar. I just want to know that the audience will be muted during the presentation. If you have any questions or any comments, please enter your questions or comments into the chat box. Also, I want to let you know that you will receive an email post-webinar with the survey link and the link to the recorded webinar, so you can have access to this. Before we get started, I would like to take a moment to respectfully acknowledge that the University of Arizona is on the land of and territories of indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and indigenous communities through education offerings, partnerships, and community service. I also want to acknowledge that we don't have any conflicts or financial interests to disclose. We are not licensed medical professionals. Information presented in this webinar is for educational purposes only and not to be used to diagnose or treat medical conditions. And now it's my pleasure to introduce you to our presenter for today. We're very excited, Dr. Natasha Mendoza, who is the Associate Professor at Arizona State University School of Work. She got her Ph.D. from the Ohio State University, her postdoctoral training at SUNY, Buffalo's Clinical and Research Institute on Addictions, and she has expertise on substance use and co-occurring disorders, harm reduction, community research, wellness, identity, and the impact of power and oppression on behavioral health. So it's my pleasure to welcome Dr. Mendoza. Thank you.
Thank you. By the way, that typo should say the School of Social Work. I'm an associate professor in the School of Social Work at Arizona State University. I'm also the research director at the School of Social Work. Thank you so much for having me. It's quite an honor to be able to talk with everyone today. I'm going to put my slides up. So let me get to that. Okay, and now I kind of need to move y'all's faces a little bit. Okay, so today I'm going to be talking about individualized approaches in treating substance and opioid use disorders, and all of that with the goal of personalizing the recovery process. And this might be a little bit of a different take than maybe in the past. So I'm not going to talk about cultural competence. I'm going to talk about worldview and how you might approach your work a little bit differently. So stick with me. Our learning objectives for the day are related to understanding the key factors that influence substance use disorder and opioid use disorder in particular. We're going to discuss and apply some knowledge of diverse treatment approaches to create individualized treatment plans, but not too much in depth. I'm only going to go in depth in a couple of different areas that I feel like don't really get a lot of attention. So we'll kind of pick and choose what approaches we're going to look at more closely. And then we're going to evaluate some emerging trends, some strategies, and think about how we might take some of the insights from what I'm talking about here and to apply it to our actual practice, whether that be one-on-one clinical practice with somebody who's challenged with substance use, or whether that be working our administrative position, or working on policy, or working on community advocacy or prevention. I really think these ideas are sort of translational. So I hope that that is true, and I hope you agree with that sentiment once we get to the other side here. So yeah, there's my picture again. And I'm real sad about that typo, but I guess I'll fix it the next time around. I want to also tell you that I have been in practice for a long time. I've been a clinician all through my entire education. I actually started really early on um, working with adolescent girls who had what we referred to as um, severe emotional issues. And so that would have been when I was in my early 20s. And that's when I started doing the kind of work that we're uh, talking about here, this really close and careful interpersonal therapeutic work. As I moved through my education, I went on to my MSW, trained as a social worker. I was doing case management and child welfare. So at that time, I was doing investigative child welfare casework where I would have to make decisions about whether or not children were in a safe enough environment to stay in their family homes or if they needed to be placed into foster care. I was helping, make huge decisions uh, really early in my career um, about how children achieved permanence in those systems. And then as I moved on into my doctoral program, I started really thinking about um, systemic gaps and bridges between mandated treatment systems, treatment for substance use disorder, and other systems where people are kind of coerced into treatment. So, what I mean by that is they're mandated through maybe the child welfare system, or they're mandated through drug court or the criminal legal system, or the criminal justice system, rather. And so, in thinking about how that process can be better, that's kind of how I moved forward into my career. I wanted to understand how I could, fill the gap in understanding related to how treatment systems could work better together. And so over time, I ended up specializing more so in the treatment of substance use disorder. And so these days, I fancy myself a bit of an expert in behavioral health with really strong focus on substance use disorder, and even more so, a focus on how substance use disorder and behavioral health are influenced by our identity. So that's the frame that I bring to this work. Um, that is over 25 years in the making. Here's our agenda for today. I'm going to do some SUD 101 to start us off with. I'm sure it's not going to be news to anyone. And then I want to talk about syndemics, which is a framework and a worldview, which might be new to some of you. Probably not the ideas, but probably in thinking about them this way and how we can take some of that worldview and translate it into a more personalized treatment approach. I'm going to talk briefly about treatment approaches, but I really want to highlight a couple different things. I want to talk specifically about contingency management and then specifically about technology and app-based supplements that could be used to support treatment. We'll hit on diversity, challenge and relapse and prevention, some recommendations about how to think about those things and address those things such that not only treatment is personalized, but also so that relapse prevention can be personalized. We'll have a bit of a treatment planning exercise if there's time. So we'll kind of we'll either introduce it and then you can maybe do it on your own or with your supervisees or with your supervisors, or we can maybe have a chance to talk about it. But I definitely want to leave time for discussion. Okay, moving right along. So, right now, this is obviously not a secret to anybody. We have quite the opioid situation, and it's pretty intense. So in 2020 or in 2022, we saw this peak with over 100,000 people having opioid involved overdose death. And it has continued to rise, right? And so what we know about this phenomenon, this situation where substance use disorder is affecting over 6 million people globally, we know that that is not occurring within a vacuum. We know that there are multiple things that influence this phenomenon of substance use and specifically opioid use. And so I really want to talk about the ecological systems that surround the phenomenon of use. So that's kind of where we're going to land. And that's where we're really going to take the rest of the conversation. Okie dokie. So, you know, this presentation is about how do you individualize treatment? And I'm going to suggest to you that there is a very simple answer to that. And that simple answer is that you change your worldview, that you can think about individualizing treatment best by simply changing the way that you understand ecological systems and the way that people interact within those systems. If you're trained up as a social worker, it's probably pretty easy because, like, from day one, when you're a baby social worker, they absolutely just hammer that home that people really develop within the context of their ecological environment. It is absolutely true, and it needs to be thus considered in everything that we do in terms of the social services that we use to address the issues that people are dealing with. And in particular to this presentation, their substance use issues and challenges. Okay. So let me talk about syndemics. So syndemics are a framework for understanding the social and health conditions that arise and interact that are driven by what we would refer to empirically as upstream factors. So the term itself combines the words synergy and epidemic, and it was a concept that was developed by Merrill Singer in the early 1990s. And the idea is to highlight the sort of interconnected nature of health and social problems among people who were historically marginalized and underserved. So the idea is this. So diseases do not exist in a vacuum. They do not exist in isolation. Population health is in fact influenced by multiple factors. Individual health is in fact influenced by multiple factors, like social inequality, like climate change. So syndemics are really characterized by this sort of aggregation of two or more concurrent and or sequential epidemics in a population. And it usually has a biological interaction that worsens health outcomes. So unlike a pandemic, which has these sort of global impacts, syndemics are really focused on regional manifestations. So these are trends that you see sort of more locally, more within a state, more within a city, more within a town, a county. They emphasize the sort of interaction between multiple health conditions and other sort of compounding effects on populations. And the idea is that health outcomes overall are going to be exacerbated when these conditions interact. So syndemics also highlight, and thinking about the world through this framework of syndemics, also highlights how certain populations are more affected due to specific kinds of social and environmental conditions, things like poverty, things like stress, climate, maybe structural violence, things like that can also contribute to health disparity, and notably are different based on region, potentially. So syndemics were initially studied by epidemiologists and medical anthropologists, but the focus really is and always has been on public health, on community health. So I'm sort of taking this idea that is sort of very high level and I'm asking you to pull it down into the individual level. I'm going to talk a lot about that. But more on syndemics, I think the other things I want to mention here is that it's really about understanding how these health conditions are interacting. And it's about having a complex and comprehensive understanding that the interaction of conditions really exacerbate outcomes at both the population level and I would argue at the individual level. And that because of that, there's also this need to think about interventions that are integrated. Duh, right? Like that just is an obvious outcome of this kind of thinking. Like we cannot think about the conditions that we work with as occurring within a vacuum. We have to think about them within the ecological system. So the framework really encourages not just looking at the world in this sort of complex way, but it also encourages thinking about intervention in a complex way. That you have to think about intervention from a multidisciplinary perspective. You have to think about intervention as collaboration. You have to think about intervention as involving multiple kinds of interventions, multiple kinds of supplemental approaches. And so all of that to say that the bottom line with respect to individualized treatment is this. I would suggest to you all that the best way to address the opioid syndemic is that we need to consider co-occurring mental health. We need to consider infectious disease, and we also need to consider the social determinants of health when we individualize treatment plans. Okay, so there's multiple factors that contribute to this whole syndemic situation that I just mentioned. But the important things for us to consider as clinicians are the economic and social factors, healthcare barriers, and the potential for overlapping epidemics. So from an economical and social place, we're considering forces that sort of might influence our clients' or patients' ability to seek and then access treatment, all right? So things like housing, things like the ability to be close to those services, things like transportation. With respect to healthcare barriers, we should be considering things like availability of resources to support treatment, such as insurance, such as Medicaid. And then, of course, with respect to overlapping epidemics, we have to be considering sort of these other complicated healthcare crises. Right now, one in particular, one health crisis that we should consider right now, if you are anywhere near Central Arizona, is heat, right? Like the potential for there to be a very strong and important implication of the interaction of ridiculous environmental heat and behavioral health. Really important to consider, which has really specific implications for people who use opioids, right? Other factors we have to consider when thinking about individualizing treatment and treating people holistically is the availability of integrated care. So there's like these systems in place, integrated care systems in place that address both physical health components that come along with behavioral health issues. And so we should be taking care to ensure that those physical health components are in place alongside behavioral health components. If not at our own agencies, then how does it happen outside of our agencies? We have to consider the availability of harm reduction strategies. When folks choose not to go into treatment, which is a wholly valid decision, what is in place then to help them manage their own substance use? And lastly, we also have to consider policy. So huge implications for policies that either close or open access to more community supports. Where are those available? Are they available? For how long they're available? So let me give you an example of that. Recently in Arizona, in Phoenix and surrounding areas more specifically, with really important implications for our surrounding tribal communities, we recently had a crisis related to recovery housing, with really serious implications for people that were living in recovery houses that were not appropriately licensed by the state. So what happened was these homes were not appropriately licensed by the state. And so the state moved very quickly to shut down inappropriately licensed operators, which is a good thing. And also what happened was a lot of people lost resources in housing very quickly. And so that then created a whole other crisis, which meant that other services had to stand up very quickly, right? Like we had to 211 had to come in and create a whole other crisis line just to help people manage being essentially kicked out of their home overnight and like maybe having no place to go and having no support services in place. So with respect to that example, and then thinking about it from the provider perspective, like if you're a provider and you're working with someone who has uh, been immediately moved out of their home and you have not thought at all about their ecological potential for instability in housing, then probably it would be a lot harder for you to help that person navigate a new place to stay and sort of know what to do in that particular instance. And my guess is there was a whole lot of providers that were very challenged with supporting folks as a function of this horrible crisis. Okay. Moving on here. So, on the really individual level, on the really sort of micro level, we also have to consider, with respect to individualizing treatment and treatment planning, the predisposition for enduring substance use disorder diagnoses. We might need to consider environmental factors surrounding the person who's in treatment, such as their family dynamics, such as their culture, and how those sociocultural influences might actually impact the way that people achieve lasting recovery. So here's what I mean. Specifically, there's clinicians who are really and truly culturally attuned to individual needs. Um, and that's really important. So notice that I'm talking about cultural attunement and that I'm not talking about cultural competence. And I would suggest to you that in order to be good at your job and to really meet an individual's needs well, that you want to be culturally attuned because it's not enough to be culturally competent. I'm going to talk about that more in a minute. But what it could mean is that you, as a clinician, as a practitioner, have really thought through, because you've thought through an individual's best development in their ecological system, what kinds of things could ideally be in place from a cultural perspective that can help them best achieve lasting recovery. This could be things that have a spiritual component potentially. They could be things that are faith-based. It could be things that you have not thought about because you have not looked into it and you haven't had a really good conversation with your client or patient about the sort of things that are more sort of part of their cultural foundation that could really help them maintain lasting recovery over time. I'm thinking of things like prayer. I'm thinking of things like meditation. I'm thinking of things like sweat lodges. If and how those are incorporated into the treatment planning process, I think is probably hit or miss, right? So let's talk about the treatment planning process. So how do we personalize treatment strategies? Well, I think the first thing that we do is assessment, right? So we try to do it through assessment. We are all taught here. We've all been taught, I'm sure, if we have anything to do with the practice community. So maybe not all of us. I actually don't know who's in the room. I'm making a lot of assumptions about who's here. Anyway, potentially we've been introduced to this notion of assessment, and we've been introduced to the notion of biopsychosocial assessment, which takes into account the biological, the psychological, and the social context of an individual. So when you do a biopsychosocial assessment, you're going to ask about people's physical health. You're going to ask some questions about their psychological history. Maybe do they have some mental health issues? You might even be asking, like, how are their relationships with their family members and if they have a support system. However, I would challenge us to think about assessment as if we're taught to assess people within the context of an ecological systems framework. And I want you to marinate on that for a minute because it's a bit broader and it's a bit more complicated than a biopsychosocial assessment. And it definitely blows us up out of a microsystem just a bit. So with respect to tailoring treatment, we want to think about creating treatment plans for individual needs, for individuals who have these unique situations for individual needs. We're certainly trained to do that, but I would ask us to do it in consideration of the ecological systems in which they can recover in. And with respect to monitoring and adjustment of these treatment plans over time, how can we do that in a way that allows us to understand and value within treatment planning processes that these systems are dynamic? Both the ecological system and the treatment plan itself are dynamic, should be dynamic, are and should be flexible tools. And that's how you can best That's how you can best individualize treatment, in my opinion, in my humble opinion. So some ways, so how are we gonna treat people? Well, probably if you're thinking about opioid use disorder, then you're thinking about the gold standard for treating opioid use disorder which has to do with medication for opioid use disorder. Um, so that's kind of maybe a given, but the other thing that I would challenge you to think about are some of the other ways in which medication can be used to treat individuals in treatment for substance use disorder, ways that are not used often, ways that are not traditionally used, but ways that have been empirically well proved, like the use of naltrexone for alcohol use disorder, for example. Naltrexone is not a common prescription for people who have diagnosed alcohol use disorder, and it has a very solid empirical grounding for being effective with people with alcohol use disorder. I don't know why that's the case, but I can tell you that's the case. And so in thinking about individualizing treatment, are our providers like really understanding the ways in which that medications can really be used and leveraged outside of how we think about opioid use to help folks with other substance use issues? We might use cognitive behavioral therapy, for example. We might use dialectical behavioral therapy. Trauma-related therapies might be important to have in a treatment setting. All critically important. We know that, most of the people who end up in treatment have had trauma historically, so that's all really important to do. And one thing that we actually don't talk very much about, and I rarely see anybody talk about, is contingency management as a means to individualize treatment. So I want to talk about that more. Let's see. We also have this really cool opportunity as treatment providers to incorporate holistic methods in treatment. That's a really important way to individualize treatment plans and individualized treatment. So for example, we absolutely know, without a doubt, that exercise, moving your body, exercise, is empirically proven to help people achieve lasting recovery from substance use disorder, without a doubt. And yet, is it ever really included as part of a treatment plan? How about nutrition? We also know that there's a nutritional component to achieving lasting recovery. Is that ever included as part of a treatment plan? It's definitely something that can be individualized, and it's definitely something that can be adding to the direction of lasting change. So why not add those things into the treatment planning process? So I would challenge you to think about some of that. And lastly, I don't think that providers think a lot about the use of technology or leveraging technology to individualize treatment plans or treatment. We are, of course, by virtue of having come through COVID times, thinking a lot about telehealth and how telehealth can really help people access treatment. Absolutely. Can it help individualize treatment? Absolutely. And that's one kind of technology I think that is gaining a lot of momentum. It's great. I want to focus on a little bit these sort of app-based technologies that can help supplement treatment. If just because I don't hear a lot about that, and I don't think people know a lot about it. So we're going to focus on those two areas that I'm of the opinion we don't really talk a lot about in terms of individualizing treatment. However, before we get into contingency management and technologies as ways in which we could potentially individualize treatment, I think there's some bottom lines that I can make really clear. If individualized treatment occurs and within ecological systems that are considered, people can thrive. And that means also proactively integrating thinking about not just what your patient client culture is, but how can those components be integrated into treatment plan. Not just thinking about what basic needs are, but integrating them into treatment planning and individualized treatment. Not just thinking about physical health, but thinking about ways in which treatment itself can be supplemented to better physical health, because we know that that sets somebody up for more lasting recovery, more lasting change. so on and so forth. I think I can do the same with each bullet here. We have to think about how people are best developing within the context of their environment. This is a very sort of person in environment approach. So if you're a social worker, you should be familiar with that language. It's the notion that individualized treatment happens when we consider not just the individual, but their environments in which they can thrive. This is on its own slide. It's one of the bullets, but it's on its own slide because that's how important it is. It's separate and apart from the earlier list there because I believe that this is another component that's often missed, but crucially and critically important in terms of considering individualized treatment. Again, I had mentioned it before, but that component is really cultural attunement. So cultural attunement is really more than cultural competence. It is a term that was coined in part by my colleague at Arizona State University. Her name is Dr. Kelly Jackson, in collaboration with her colleagues. It is not just about understanding, it is also about respecting and leaning into cultural differences to provide effective care. So it's not about creating treatment plans that just name cultural differences. It's about creating treatment plans in consideration of the systemic power and oppression that exists within the ecological context. At the very least, it's about thinking about those things whilst you're creating those treatment plans. So I challenge you to ask yourselves, is that something that you think about? When you're putting together your treatment plans, when you're thinking about individualized treatment or what it means to even consider a single person, are you thinking about the ways in which they are subject to the oppression of the systems in which they live and work? That's my challenge to you. Before we move on to those specific examples, I want to say a few words about relapse prevention because this is also an area that we want to think about individualizing. There's also an important reason here to consider ecological systems. When we think about relapse prevention planning, we want to help people maintain the change that they have achieved in treatment. And so with that, I will say a really important and not very often thought of component are alumni communities and how best those alumni communities can be leveraged for people who are currently in treatment. So if you are a provider or you're a provider who's part of a treatment system and it's not clear to you what's going on with the people who graduate and are successful in your program, then I would suggest to you that that is a major gap in services and that should be addressed ASAP. If you don't have a system of alumni with whom you keep in contact with, then you're kind of missing out. Not only are the people who are leaving your services missing out on the potential for a community that could really help them maintain their recovery, you yourselves are missing out on that really great, like, community-based word of mouth. Because when you stay in contact with people who are successful with your programming, that's the kind of thing that grows and spreads and disseminates. And that's how your agencies get to be really well known for the success, because you've got really solid alumni communities that continue to stay attached. And you also are able to continue to stay connected with your alumni. So I just want to highlight contingency management, and like I said, it's because it's not often talked about very much. And in terms of how it can be used individually, like in an individual way, it's not altogether clear from an empirical standpoint. But I want to talk about it because it is a treatment approach, and it's a treatment approach that I don't think has a lot of use. So maybe you're using it at your organization. If you are, kudos to you. I think it's kind of a complicated thing to bring into your organization and to do it well and to do it from a place of fidelity. So let me at least introduce it here. So contingency management is one of the only based behavioral health interventions that are shown effective in treating stimulant disorder. I'm talking really specifically about stimulant disorder here. So in terms of individualized treatment plans, this is an approach that's really potentially helpful for people who have a stimulant disorder, not just on its own a stimulant disorder, but it's also really effective for people who have um, polyuse disorders, but also really use stimulants. And so here's how it works. Um, the sort of target behaviors of use are identified, um, as well as the the goal, which is typically abstinence or adherence to treatment protocols. So it doesn't have to be abstinence, but it is typically abstinence if you look at the empirical information surrounding contingency management. Um, so, in thinking about like, do we want to bring these kind of ideas into our organization or into your own treatment systems? You can be thinking about it a little bit more creatively. I don't think you have to think about it simply as, people are testing negative when they have your analysis. You can be thinking about, achieving different treatment plan goals and that are maybe not even associated with use at all. So you can think about it differently. Um, Monitoring usually happens, as far as the empirical knowledge base goes, by monitoring urine tests or other methods to verify the decreased use or abstinence. Um, and also, it can happen with other treatment goals, so please hear that. Incentives are related to patients receiving tangible rewards. So it could be money, like vouchers, could be cash, cold cash. Um, and it can also be different kinds of things that are of value to the individual. That is critically important. So it could be money. I think we have a objective valuation of money, but it can also be things that the individual person finds to be very valuable. Maybe it's like, I don't know, if there's like maybe there's something they really enjoy doing, and maybe there's like extra time available to do that as part of their treatment milieu now because of whatever. I'm sure you guys are more creative than me. But anyway, the benefits and the effectiveness of contingency management are that it's really been shown to significantly improve abstinence rates, especially for people who are struggling with stimulants. Um, some things to make note of is that it's important to provide immediate reinforcement because it's really important for people to connect positive behavior change with positive outcomes. That's an important part of it. It can be used alongside other treatments. So it can be used alongside any other of the other behavioral health interventions I mentioned before, or medication for opioid use disorder or substance use disorder. Um, from an empirical standpoint, I'll tell you that numerous studies have demonstrated the effectiveness of contingency management for reducing use, just overall. Um, and like I've already said, very successful with stimulants. Here's the challenge. Implementing this kind of intervention in a treatment setting can be pretty resource intensive because it requires some kind of incentive to be given to the person who who has the positive behavior, right? So thinking creatively about how people can view incentives might be worthwhile. So let me give you a creative example. Here's the thing you might do. There's a treatment center, I won't name specific organizations, but that has a store. And by store, I mean store in air quotes. It's kind of a store. And it is made up of donated goods. And these donated goods are really cool donated goods. They're not just like cast-offs. They're things like they've had hotels donate like beauty products. They've gone to stores and they've had like brand new clothes donated. They've had um, lots of donations that were not like money donations, but stuff that's new, stuff that's really valuable. They've had huge donations of stuff that's really useful personally. Like if you have children, they have huge donation of diapers or personal hygiene products. Um, you name it, they have it donated to the store. And I use store in air quotes because it's not a store where money is exchanged. It's a store where, there's kind of like play money, like bucks. that can be used. And it's set up very much like a store. So people can go in and they can go shopping, which is its own kind of cool experience, especially if there's cool stuff. And so the incentive that gets earned are the bucks for the store. And so this is a really creative way in which contingency management could be implemented, but that's not wildly resource intensive in terms of actual hard cash money. However, it is resource intensive insofar as you need to have a development person that can go out and sort of seek out those donations, which is a little bit of a challenging thing. But if you find the right person, a good development person, worth their weight in gold. So let's see. In As far as individualizing treatment, I think one thing that's cool about contingency management is that it can be customized to meet the specific preferences and motivations for individual clients. That is a thing, that is possible. It is a matter of creativity on the part of the clinician. However, even though that sounds very subjective and like doesn't have a whole lot of fidelity, there are systems in which there is a lot of fidelity and you can see them for yourself. There's links here. You can go to the Pacific Southwest Addiction Technology Transfer Center eLearn site, which is the link on the bottom there, and you can learn all about what manualized contingency management looks like if you are seeking to implement that kind of thing at your organization. Alrighty. So, what does that look like? What does it look like when it's really high fidelity and really manualized, really objective and less subjective, which is to say maybe not as individualized? It's a 24-week program. It involves testing for stimulants. It involves a maximum of $600 over a 24-week period that's handed cold cash over to a client base. And it involves tracking progress with an incentive management service that is not just about the clinician, but also about mediators that help track progress. So you can see what it looks like in a manualized way, and then you can think about how can I adapt this in a way that's really individualized for my client or patient. Okay, quickly we'll move on to technology. So for a hot minute, I had an affinity for mobile health and I tried to build an app and it was really, really expensive. And it was a cool idea, but I couldn't get it off the ground. But I really did come to value the fact that a lot of people like their phone and a lot of people really make the best use of their phone in ways that are not just scrolling through Instagram. There are a lot of really helpful apps out in the world, and they are empirically sound. I know that is a hard one to hold on to for some folks, but really and truly, there's some mHealth apps that can be on your phone that really are useful, empirically sound apps that can absolutely help supplement treatment and individualize a treatment plan for your client patient. So, what do? Well, they might do things like educate. There's some sobriety trackers. They might have to do with medication management, meeting appointment trackers. There's the kinds of apps that can be used between a clinician and their client so that you can be communicating off of session time and you can, just really have some different kinds of treatment plan accountability happening more often. There's peer and community support apps. There's harm reduction apps, which I should have listed but didn't. There's harm reduction apps that will let someone know that you're planning to use so that in case they don't hear from you in a certain amount of time, then they can call emergency services to come and ensure that you're okay so that you're not overdosing. There's apps for that. There's apps to track good habits. There's apps for relapse prevention and management. There's apps that include directories and maps for, say, locating harm reduction services. There's apps that have gaming features in them to sort of make this change process a bit more fun. So let me give you some examples. There's an app up there on the top left there. It's called I Am Sober. It's recovery time tracking. It has lots of motivational messages. You can track other things in it. And it gives you access to a community message board of other people who are seeking recovery. There's Lucid, which is a direct connection to local recovery peers, which is great. These are people who have been through it and can help with it. It includes inspirational content. You can sort of build out more of your own community. There's even a dating component to it. There's, recovery-friendly social events that are listed in your area potentially. Like, how much would it be great to be able to walk a client or a patient through? Like, these are the resources. Like, you might find some value here in terms of achieving recovery, especially once you get out and are managing recovery on your own. And you're trying to find ways to do that that are healthy, ways that are, in the support of, in the community of people who are also trying to manage lasting recovery. Another example is the Phoenix. Some of you might have heard of the Phoenix. The Phoenix is not referring to the city Phoenix, it's referring to the company, the Phoenix. The Phoenix it started off as this sort of fitness-based, functional fitness-based company in Colorado. And they did like recovery CrossFit meetings. And they had this like fitness community of people that would get together and work out together. And then they started to grow and started to become more of a system of recreation for people who are in recovery. And now they have an app. Like they've been around for at least as long as I've been a researcher. And now they have an app. It's a really cool app. And so what you can find on the app are events, classes. You can join live stream yoga classes, all with people who are in recovery from substance use disorder. There's community support. There are message boards. You can have, groups of people who you meet at the different events that you might go to. There's goal setting and tracking. So here's an example of when I just was looking at the app yesterday to be like, what's going on? So I could talk about it today at this meeting. There is one of our leads for our recovery home advisory board apparently is a climber. He's a guy that likes to climb, knows a lot about climbing. He's a volunteer for the Phoenix. And he put on one of the events, because there's volunteers who run the events in the community. And one of the events is he's going to be at a climbing gym this weekend. I think it's on Sunday or something. He's going to be at a climbing gym on Sunday. He's going to help people who want to go in the spirit of recovery, either learn how to or climb, to be in this climbing gym all together. And so how cool is that? It's like a recovery meetup, right? It's a way to like hang out with people who know a lot about maintaining lasting change and recovery. It's a way to build community. You can go meet Tom, who's obviously really strong and knows a lot about fitness and climbing. So you might catch on it with a new hobby. Like it's just such a cool thing. And I think that probably we don't know a lot about these things as clinicians. Like they're really interesting ways in which they could help supplement and individualize treatment plans. And here's just a little bit of a commercial for you. So I am charged with running our opioid initiatives at Arizona State University. And so here's some resources to that end. You'll get the slide deck so you can capture the links there, but we have a lot of resources for patients and families and providers, and they're free. We are funded by Access through our state opioid response to offer these products. So like, for example, we have an MOUD 101 course that would be great for the new behavioral health tech in your life. It is a fully functioning and free MOUD 101 course. They could take it right on our website. We have a whole Recovery Home of Arizona, which is lots and lots of content about how to be great peer supports in recovery homes. And I'm seeing Bianca come on. Is that because you're trying to cut me off, Bianca?
No, I was just gonna come on for the question and answers. So
Okay. All right, I'm running through. We also have an overdose prevention guide that's really really good based on local Arizona empirical information. And we have some MOUD consumer and provider guides. So we can send those to you free of charge if you just let us know that you want them. This was the treatment planning exercise we will not get to, but I really, really encourage you, if you would, take a look at the slide deck when you get the slide deck. If you are a supervisor, I really encourage you to work through this exercise with your supervisees and vice versa. If you're a supervisee, drag this slide up to your supervisor and just have a conversation about it. I think it could really help widen your perspective when it comes to individualized treatment. And with that, I will uh, shut it down, but I do want to let you know that all the links to the app are back here on the reference slide. Okay, there we go.
Thank you, Dr. Mendoza. That was an amazing presentation. Um, so does anybody have any questions? I'm not seeing anything in the question and answer box, but feel free to write those, or if you want to unmute yourself and ask a question as well. Now is the time.
Well, I have a question, and just out of sheer curiosity, there are those of you that are in the room. Is anybody already using contingency management or any app-based supplements in their treatment planning?
Anybody want to answer that?
So while we're waiting for folks, if they had can put it into the chat, that would be great. But I also wanted to just jump in here. Since we made you the host, I wasn't able to put your links into the chat. So we'll make sure to get those to folks. But one question I was thinking about, I loved the example of how an app can be used to get people into a setting so that they have that human connection. And I just think so much about some of the work that's been done about loneliness and, really the importance of this human connection, and thinking about community health workers or peer recovery supports. Can you just talk about how some of these types of efforts could also be incorporated into individualized recovery?
Yeah, I think that the way that it happens is through collaborative treatment planning. I mean, I think that maybe the treatment goal would be to increase social supports, for example. And so then I think there's a really strong place for the clinician to help brainstorm, what does that look like? What are some ideas? Certainly that, the ideas are best if they're coming from the client or patient. However, like these are great ideas, maybe it would be worthwhile if if our treatment planning goal is to increase social support systems that value recovery. Maybe you could give one of these apps a try. Like I don't think there's value in doing it in a really kind of coercive way, I guess. But I think they're great suggestions. And I think that they can happen during that collaborative treatment planning process, at least as a conversation, if not a specific like line.
That's excellent. Thank you.
And I have a question, Dr. Mendoza. That event that you mentioned that's going to happen, is there any more that are going to happen, or maybe more in Tucson and other locations?
From the Phoenix app?
Yes. Like, is that just based on
Yeah,
Phoenix? We don't know if there's any that,
no.
okay.
So it's the company, the Phoenix, but when you
Okay.
go into the app, you tell it where you're at. So if you're in Tucson, you're in Tucson. If you're in Oregon, you tell it you're in Oregon. But it is a national app. And the app will organize events around you wherever
Nice.
you're located. So the ones that came up for me were in and around Phoenix, and there's a whole bunch of stuff happening. There's hikes happening. There's the climbing gym stuff that's happening. There's virtual stuff that's happening that you could join if you're not in a place where there are any local events that are being hosted by volunteers. So yeah, I think check it out. Like it could be that you're missing out on a community that's really cohesive and meets all of the time to go hang out and do really fun, active things.
I love that, and I think I'm going to let others know about that app because it's an amazing resource. Okay, and it looks like there's some questions. Okay, so I'll read them to you. Is there studies on sober living issue in terms of trusting the healthcare system and continuing treatment for those individuals?
Studies? No, not yet. But I'll tell you this, there's quite a bit of momentum in the recovery home space. And um, in terms of research. So right now, there's there's a movement called iStar. It's a little I, capital STARR, and I forget what it stands for. Something something recovery residences, but it's a national empirical effort to really better understand recovery homes and outcomes associated with recovery homes and how to best program those recovery homes. So I think that might be a thing you could probably Google and take a look at.
Correct. And then we have another question. As a peer and recovery support specialist, what might be helpful things to consider when working with someone in a CM program?
That's a great question. So here's what I will say, and not specific to a contingency management program in particular. I think what's really important to consider with working with any individual is having a really strong, clear understanding of what it is they value for themselves. And I don't mean high level symbolic morals and values. I mean tangibly, what do they value? Do they value more time with their kids? Do they value, time riding motorcycles? Like, in terms of like how can they envision for themselves a really healthy life free of substances or at least free from problematic addiction so that they can really thrive? Like, what does that life look like? And sort of, remembering to ask those miracle questions. If everything changed tomorrow and your life was perfect, what would your life look like? If we, clinicians and peer support specialists, have a good understanding of what that means for someone, then we can help leverage those things with that person in collaboration such that they can see themselves and then get to that place to achieve lasting recovery and change.
Thank you. And any more questions anybody would like to type in? Okay, I think that's it. Anything else, Dr. Mendoza, that?
No, thank you for the opportunity. As always, it's fun presenting with you all, and I know we'll stay in touch, but I hope I get another opportunity to come and do some more teaching about something else. Well, thank you very much.
Thank you. We loved your presentation. Thank you, everyone.
Bye.